And thanks to NATF for the opportunity to be here and share part of our story. It's really impossible to express what a tremendous honor it is to just be here among such great practitioners and such champions for VTE prophylaxis. University of New Mexico Hospital is located in Albuquerque. We're a 500 plus bed academic teaching hospital. We're the only level 1 trauma center in the state. It sounds like there's a common theme. We have a large population of morbidly obese patients at our hospital as well. We also serve a large oncology population. So with those multiple high-risk populations at risk for VTE, this is a major focus for us. And I must mention 2 hospitalist champions from my hospital that weren't able to be here, Dr. David Garcia and Dr. Kendall Rogers, who really were the visionaries and catalysts for this project. This is just a slide referring back to what Dr. Pendleton was talking about, the hierarchy of reliability, a quality improvement tool where if you're doing nothing, you're not performing well, and as you add layers of intervention, your performance goes up. So peppered throughout my presentation, you may see references to this as to where we felt we were performing at the time. So we've really been focused on this for about 4 years, and when we started, we had a draft of a protocol, but it hadn't been formally approved or implemented, and there wasn't really a gelled group working on this collectively. So we considered ourselves stalled at level 1, and that's when our hospitalist champions approached hospital administration. We're really able to communicate the vision on VTE prophylaxis and get us moving in the right direction. So, in the same vein, one of our first interventions was to create a protocol, and our first version was actually what we feel was the best. It was actually an interactive PDF, which we think is far superior to our CPOE product that we have now, but we couldn't translate this into CPOE. The key points are we chose a 3-bucket model to make it as simple as possible to promote uptake, low, moderate, or high risk, and it does include opting out in the event that a physician chooses not to prophylax but needs to provide a reason. And our goals were really just to embed it into everyday workflow, but to minimize workflow interruptions. We did layer upon layer of supportive interventions to augment that protocol. We identified dedicated resources, as many of you have. We also did quality tracking through real-time chart audits and feedback on performance to individual units and services to recognize strong performers and also encourage those that may be deficient to improve their performance. And then, as always, education in services to anybody that would invite us to talk about the topic of VTE prophylaxis and also appropriate use of the protocol. So some additional layers, if you have more sets of eyeballs on a problem and you can offset the perspectives, events are less likely to slip through. So one thing we tried to do with that was to add other people's eyeballs to this problem. We recruited case managers on rounds. We recruit pharmacy residents, pharmacy students to talk about VTE prophylaxis status on patients every single day. We also had providers and all nursing units add VTE prophylaxis status to their handoff reports. So at every shift change, physician to physician report and nurse to nurse report, VTE prophylaxis status is getting talked about. And we're seeing this as preventing adverse events. So just data collection really quickly. I think this is one of the most difficult things of this initiative is just to figure out the means and the methods to get the data. So we do have a means to run a report, a census report of patients admitted to the hospital in the last 48 to 72 hours. And then we use a random number generator to identify patients for audit, and we have a standardized abstraction tool. And one of the key things is we look for prophylaxis. We consider appropriate type, dose, and duration, which we weren't previously doing, and I'll expound on that here in a moment. This is a very busy slide, but I want to walk you through it because it's really our journey in totality. But a couple of key points, what we're looking at here is this bottom line is rates of use of our protocol, okay? So at the beginning of our journey, we didn't have it implemented, and it starts creeping up. And here's our state of nature, about 40%. So we start implementing layers of intervention, and then we had an opportunity to go to a collaborative in St. Louis, and we learned from other hospitals, much like here, and what we found, we were really just looking at any prophylaxis, and we were kind of overselling ourselves. And so we reassessed that, and we went back, and what we found was that if we really looked at appropriate prophylaxis, meaning type, dose, and duration, we weren't performing as well as we would have liked. The other thing I think that is kind of a recurring theme here is that you have to make the protocol, like Dr. Murley said, you got to pull people through it or force them towards it. And so what we did is we went back and we got administrative buy-in to make the protocol mandatory to be placed in every chart when it was in paper form, and empowered staff, both pharmacy and nursing, to call the providers and have this completed in a timely fashion. So you can see when we did those two things, rates of use of the protocol went up, and not surprisingly, because there's decisional support included in the tool, rates of appropriate prophylaxis went up as well. And then another boon for us was the implementation of CPOE, where we were able to take our tool, embed it upstream, and push all providers through it. So that helps us sustain high rates of use of the protocol, and also rates of prophylaxis, helping us approach level 4 on that hierarchy of reliability. As far as the hospital-acquired VTE incidents, this is another thing, if you haven't gone through this experience, is meeting with several departments to figure out how to get the data fed to you. We get data from both radiology and vascular. This is one of the areas we're really trying to optimize right now and streamline, make it more efficient, so it'll facilitate more rapid data analysis. And we do try to control for hospital census volume by reporting 1,000 patient days. Here's our trend for hospital-acquired VTE incidents over the last couple of years. The trend line is moving in the right direction. Again, we'd like to have more frequent data collection points and make this a more efficient process where it can be more hardwired. We've recently developed a VTE website, and we're working closely with IT to develop some databases where this data can just be dumped in and reported in real time. So considering ourselves at about level 4, how do we get to level 5? Things we're thinking about is, we've talked about process measures using the protocol, outcome measures of VTE incidents. Now we need to look at balance measures of bleeding, incidents of HIT, and doing that accurately. We also want to start doing prospective assessment instead of retrospective, and like Dr. Pendleton spoke about in his presentation, we have a dashboard that is to go live in the next couple of months where the patients will be color-coded on the unit. So a provider walking onto that unit will instantaneously have situational awareness of the VTE status of that patient population. And we, along with some of the other presenters today, we've added additional options to our VTE protocol, including obesity and renal dosing, to guide providers to the right choices in those areas. And then we're actually moving towards creating a surgery-specific VTE protocol to help them achieve those skip measures that Dr. Pendleton talked about. The last thing we'd really like to try to do, and Maynard and his group do a really good job of this, is all events are identified in real time, and then those parties that are involved are invited to talk about what went wrong and how you can maybe prevent events from happening in the future. So that's one goal that we're striving for.